Thank you for joining us today in this important workshop. It's a privilege to welcome our participants, STEAM funders, valued partners who have come together to support the Maui Wildfire Exposure Study and Health Registry. First, let me extend my deepest gratitude to our funders for the generosity and vision which have made this work possible. Your investment in this project is an investment in the resiliency and well-being of the Maui community, in particular the state of Hawaii, the National Institute of Health, the College of Social Sciences at the University of Hawaii, UHERO, which is the University of Hawaii Economic Research Organization, the Pacific Disaster Center, and the Office of Strategic Health Initiatives, which is running the Red Hill cohort. I also want to acknowledge the time and effort each of you has committed to being here. Your expertise, experiences, and insights are vital as we work collaboratively to strengthen the Maui Wildfire Exposure Study and ensure that this registry becomes a meaningful tool for recovery, resiliency, and decision-making. So we have an incredible opportunity to create solutions that will leave a lasting impact. So thank you for being here. Okay, so before we begin, I want to emphasize a key lesson from disasters. When people are struggling with housing, jobs, food insecurity, health often becomes a lower priority. While this is understandably, neglecting health during these times can worsen pre-existing disparities, especially in communities already facing higher rates of chronic illnesses. A sobering example, of course, and as you will see from our colleagues from 9/11, is that when years later happened, more lives were lost due to environmental exposure than the initial attack. So what we discussed today, we think is crucial for shaping health outcomes and building a more resilient community for the future of Maui and the state of Hawaii.
Ruben and I are going to be toggling throughout this talk to share some of the information that we've found from our MauiWES study cohort. And really, we appreciate all of you being here to learn with us and alongside us some of the issues that our community has faced and trying to understand better so that we can serve our population and hopefully prepare for the next disaster in a better way. But also to really seek deeply into understanding how to better address and eliminate health disparities that exist even prior to disasters. So I think that's one of the main findings from our work with our Maui partners. As you can see, and as you probably have heard on the news and seen videos of, and it's really horrifying experience that our survivors been through throughout Maui, not just in Lahaina, which is shown here, but also in Kula. Some of the harrowing experiences that are recorded by survivors have been reported and documented in the Lahaina Fire Comprehensive Timeline Report that's listed here for those of you who are interested. It's really difficult to kind of explain to you, especially in a talk like this, what that experience looked like and what it felt like. So having those testimonials, first-hand accounts, even video recordings from people experiencing this tragedy really is a visceral, you get a real better picture of what they've gone through. And kind of to illustrate some of the exposures that we're trying to understand how that might be connected to health, this is just one picture of what Lahaina looked like during that day. And you can see that's a smoke plume. The smoke that's there is much higher, more pervasive than that area. And so like the tree lining, like you can see that there, you can put that into perspective. Those people who were there suffering through this disaster being exposed to this during that time. So we wanted to kind of give you a better picture of the sense of that day. And in order to do that, we turned to our colleagues in the Department of Atmospheric Sciences at SOES at the University of Hawaii, who are in the audience today. And we really are grateful for them to help us put together a simulation of what that looked like, at least for Lahaina so far, with this video. And what this model shows, and this was done by Dr. Nadia Moisivia, as well as her colleague and advisor, Stephen Bolsinger, again at the Department of Atmospheric Sciences at SOES. And you can see not just how extensive the fires were, but if I zoom in here, and of course all of the smoke that was created during that time. But this is over a 14-hour time lapse, so you can see how quickly the fire after ignition just ravaged Lahaina. And it's just remarkable how tragic that event was during that time, especially in terms of people trying to figure out how to get out and suffering through that tragedy and getting the support they needed. Along with that, we also have reports from the Pacific Disaster Center, who are also here today, along with members of the Maui County office to put together what the wake of the fires looked like. And this is just out of their report, so you guys can take a look at that more carefully. Of course, with the lives lost, in addition, there's a lot of structural damage as well as damage to agriculture and on surrounding areas. And this is in Lahaina town, and you can see where the burn perimeter looks like, as well as on Kula, on the other side of the island, that also had a fire the same day, and actually took longer to put out. And again, in addition to people losing lives, there's also structural damage, agricultural damage, and others that people have suffered from. So, two big disasters on the same day on two different sides of the island made it really difficult to respond to this tragedy. I'm not going to go through all the details here to list, the wake of the fires, but I just wanted to highlight the fact that, these experiences have not just immediate early effects on the health and the well-being of individuals, but the long-term consequences. And that's something that our study is really trying to understand in more detail. And there's many reasons why we're doing that. And of course, as one of the worst disasters in the state of Hawaii and the deadliest fire in the US over the century, this threatens to further widen the pre-existing health disparities that we see in our community already. I'm a Native Hawaiian myself, born and raised in Waianae, at the knee with my great-grandmother, who is depicted here, Kupuna Catherine Maunakea, who herself was born in Kula, Maui, with 20 siblings, so a huge family there in Kula, but also throughout Maui, and of course been affected by the fires as well. So this is not just professional for me to understand health disparities, but also very personal. She actually was a hakumele, a Hawaiian healer, and she wrote the song Aloha Lahaina. I don't know if you guys know that song, mele, but it's very touching mele. And so, one of the first questions that I asked my family, we also asked Ruben, what would my great-grandmother do during this period? And she would tell us, do what you can. And what we could do, and this is something Ruben and I have been working on even before the fires happened, was our work on health disparities. We worked with many different community partners throughout the state to better understand and address health disparities that are pervasive here in Hawaii. We experienced this through the COVID pandemic and created partnerships with schools and FQHCs across the state to better inform as well as enable testing for COVID and vaccination uptake among our population that was definitely hard hit by the disaster. And so we were able to deploy our resources there and navigate that. We've also been working with our participants throughout the state to learn more about the health conditions generally and how it might be impacted by social determinants. And we've recruited more than 2,000 individuals enrolled in a biannual cohort study that's ongoing to help us understand that. And this was before the disasters. And then just before Lahaina, we also recruited 2,100 residents, primarily Native Hawaiians and Pacific Islanders, mostly on Oahu, to understand the etiology of diabetes prevalence in this population. And so we've been experiencing in our way a crisis of our own, just dealing with health disparities. And then of course, with the trauma left behind by the fires, we decided what can we do to really better understand and address these conditions that might be emerging in those that have suffered the wake of the tragedy. And so we tend to use this multidisciplinary research initiative to address health disparities in Hawaii. We blend health education and health services in our previous cohort study. So we decided, why don't we also do the same for the survivors here? And so in order to do that, we really listened to our community partners that were working in the ground. And Noi, who gave our amazing Oli today, was one of the first on the ground, boots on the ground, trying to help as much as possible take care of the health and well-being of the people who had suffered that disaster. So partnered with Maui Medics, which she organizes and runs, as well as other organizations listed here. That's also part of our community advisory board. Learned from them the best practices and also what was the immediate needs of individuals impacted by the fires, and integrated that with our research in order to understand better some of the consequences. We also put together, thankfully, a scientific advisory board. Many of you are participants in that board, so we're really grateful for your advice and feedback as well. And we thought that was an amazing opportunity to link our scientific advisory board with our community advisory board today. And then, of course, our funders and other partners that were really instrumental in helping us figure out how to logistically handle this. Since, of course, you had seen driving through Lahaina, still the recovery is still ongoing. So space was a limiting factor, but also trying to get the right support around long-term evaluation and studying participants is another logistical challenge that we face. But our initial goal was to be able to recruit a cohort, initially 1,000, but thanks to state funding, we've been able to increase that number to 2,000 individuals that have been impacted by the fires to better understand the short and long-term health consequences. And in year one, we are gathering data from participants as much as possible at different layers of information, from neighborhood, socio-ecological to cultural, psychosocial, occupational, environmental exposures, as well as individual risk factors, and also collect biospecimens to learn about molecular changes that might be underlying some of these issues. And then we plan to continue studying this population over time. We are funded with NIH support over the next 5 years to look at some of the midterm endpoints, such as cardiovascular conditions or lung health conditions that might emerge after exposures to this disaster, as well as potentially long-term outcomes that might manifest in order for us to really identify some early indicators or risk factors that might help mitigate the potential endpoints that our community might be faced with. And so we're hoping to continue this in perpetuity as much as we can. We launched the study officially on January 26th with our first recruitment day. That was the fastest we could deploy our resources and get everything set up in our community to recruit participants in the study. And this is sort of what it looks like. We were able to gather data in questionnaires, a lot of self-reported information from demographics, housing stability, food security, safety, resiliency factors, as well as exposure and health behaviors and others. We also collected biospecimens such as urine, saliva, buccal swabs, and blood samples to look at stress response, inflammation, and environmental toxins that people might be exposed to link that back to some of the health issues. We also provide a health screening service at the time of recruitment that includes examining lung health, cardiovascular health, metabolic health, of course, mental health, and also link back to medical records to look at and examine cancer risk, especially in the populations that we know that are at a higher prevalence than others. So within the first 30 recruitment days since January, we were able to enroll 1,500 participants in the study, and that now includes children, and we're almost reached our initial goal of 2,000, and we think that we'll hit that at the end of the year. So we're going to share some data, emerging data of the cohort so far. I'm going to give you, there's 3 different cohorts represented here. The first cohort is our baseline, reached about almost 1,200 individuals. These are all adults. But we also were able to deploy a mini survey to those participants, the initial participants in the cohort that we call the 6-month follow-up time point. So we were able to collect more information from the same individuals after that 6-month period to compare with some more granular information. And then fortunately, we also had a UHERO pre-fire cohort that was in existence before the tragedy. This was, the data was collected in May 2023 and about 1,000 participants there over Maui. And we were able to get some information from those participants. But just to let you know, from the baseline cohort to the follow-up, similar demographics because you're from the same cohort, but then the last cohort, the UHERO cohort, slightly different composition. So, but we do have some ways of comparing and accounting and adjusting for those differences. And so we're going to describe some data, just descriptive information from the baseline cohort, as well as in some ways compare with these pre-fire cohorts to understand some of the impacts. So for the baseline cohort, by working with our community partners, we were really fortunate to get a pretty diverse representation of communities that have been populations that have been impacted by the fires. And this includes what we think is the most comprehensive and ethnically diverse study to evaluate the short and long-term health following the disaster in Hawaii. They involve Native Hawaiian Pacific Islanders, about 20% of the population in that cohort. Whites are at 30%. Asians around 11%, Filipinos around 20%, and Hispanic and Latino population, which is typically underrepresented in many Hawaii studies, at 18%. So again, working strongly with our community partners on language issues as well as accessibility on the survey. Really, we're grateful to their partnerships for us to be able to get a better sense of what really happens in these populations that are typically underrepresented in these types of studies. We also got some good representation by age groups. Majority of the, in this initial baseline cohort were adults between the ages of 35 to 64, but we also had representations from the older and younger individuals, and almost an equal split between males and female participants in the study. For those of you that are joining us on this Saturday and maybe Sunday, if you're interested in continuing staying with us, we're gonna be continuing our recruitment event, so you'll see what it looks like on the day. And for those of you who may not be able to join us, I just wanted to kind of give you a glimpse of what that kind of looks like. This is a cartoon of our pop-up health screening stations where we recruit participants in the study and what the participants are doing with us that day. And so starting from the area number 1, we have a check-in station where participants come in, basically get informed consent, as well as the survey questions, and they complete the survey, which is about 30 to 45 minutes. And they get a little baggie of supplies that they need to go through the stations for their health assessments. And so the first thing that we have them do is to get a sample of urine to drop off at our station, and they move over to a phlebotomy station where they can get a blood draw. We also provide a point of care testing using ISTAT measures to check for blood chemistries that might present also red flags to, for any potential medical emergencies that we would have to have individuals referred to right away for care. We also collect saliva and buccal swabs, as well as height, weight, and blood pressure. We also look at lung health, measuring spirometry, and also added oscillometry measurements as well. And then we provide the results of what they've been through to that station right there on the day after they finish going through that. This is an example of what the participant result sheets looks like with salient information about their health during that day. They also get a consultation either with me or one of our nurse providers, nurse practitioners that are helping us with the study, or in many other cases as well, our internal medicine providers or family medicine providers that are volunteering with us. And they provide one-on-one consultation with participants over the results. And again, do more robust assessments on the one-on-one consultation. We also have an immediate referral to mental health providers and care on the day as well. And so, and you'll meet some of them in the audience today, and we were grateful for their support in the study. And they provide consultation on the spot of some mental health challenges, as well as referrals to services. And so while we're collecting information, participants get information about their own health, and they also get information on care if they need that. In addition to the paper copy that they get from the day, we also provide each participant with their own data portal where they have electronic version of all of the data that we collect from that screening that can be accessible to providers immediately, so that they can use that for care, for follow-up and diagnoses. We also encourage participants to continue monitoring that data portal, because we collect additional information over time, such as some of the heavy metal exposures that they might be exposed to, and we provide that information back to them on this data portal. We also provide a public-facing dashboard so that you can see what the aggregated data looks like and disaggregate that in different ways, but this is all anonymized and de-identified. And so that's live now at the UHERO website, so if you're interested, you can check that out. At least we try to make it as robust and timely as possible. So the latest data, I think, is from the May report, but we're gonna be updating that soon. And then here's the summary so far of what we found.
And some of the main trends that we are seeing in the report are mental and physical health issues, access to care, as well as housing, job, and food insecurity. And just to give you a quick summary of this, for our cohort, the initial 1,100 individuals, we saw alarming rates of mental health issues among survivors. More than 50% of participants show depressive symptoms. And again, we had a comparison cohort pre-Wildfire for Maui. That's about 30% of individuals, so 20% increase. 19% reported low self-esteem. 30% had moderate to severe anxiety. 4% had considered suicide in the past month. Nearly half of the participants reported worse health since the fires. This is especially among individuals with higher self-reported exposure to wildfire ash, debris, and smoke. Respiratory issues such as coughing, wheezing, difficulty breathing were one of the main symptoms, as well as skin and eye irritation, fatigue, weakness are basically what they were reporting. And one of the things that we were able to see is we compare the symptoms with self-reported exposure, and we saw an association. So participants who reported frequent exposure to wildfire debris, smoke, and ash tended to experience more symptoms. Another of the issues, remember that we look at blood pressure as well as the spirometry reading on site. 74% of participants face a heightened risk of cardiovascular disease due to high blood pressure at elevated hypertension levels. Up to 60% may suffer from poor lung health based on the spirometry reading that we have, with 40% with mild to severe lung obstruction. And besides the health impacts, there is also social impacts. For our cohort, over 70% of the participants reported a loss of income after the fires, with 1/3 reporting a job loss or looking for employment at the time of the survey. And again, so this may not reflect the current situation right now. This is basically what happened at the time of recruitment, right, which was 6 months ago, more than 6 months ago now. Increased difficulty of accessing medical care was another big thing for that cohort. So pre-wildfire, 1 in 10 individuals didn't have good access to medical care of medications. That's what we had from the previous cohort. Post-wildfire, we see that 4 in 10 individuals didn't have good access to care of medication. That doesn't necessarily mean that they don't have insurance. I mean, they just may not have a PPE, they just don't have transportation, etc. But one of the things that was really shocking for us was the health insurance coverage. Pre-wildfire, about 5% of the population in the state didn't have, in Maui, sorry, didn't have health insurance. Post-wildfire, it was 10%. And this happened because they typically lost employment, so they lost coverage, right? Or they just simply don't qualify. But there was a significant disparity that was very unique for the Hispanic population, where 38% of participants didn't have insurance. That just didn't happen with the other groups that we had. Increased food insecurity was another of the issues. Almost half of the respondents reported very low or low food security. And this is, again, higher than the pre-wildfire Yujiro cohort, where it was 1 in 4. So basically double the number of participants. But again, not everything is bad news. MauiWES participants trust and use community-based organizations more than FEMA or other local government services. There is, of course, a variability across different groups, with Filipinos basically using less these services than others. And trust and social connectedness is another thing that we saw. Participants reported higher level of perceived social support, tended to have less depressive symptoms than those reporting low levels of perceived support.
So that's more of the descriptive data, and so we just got some new information from new analysis from the follow-up surveys that we performed to give us a better idea of the interaction between the exposures to the fires, as well as some of these factors that we already explained, such as mental health and social factors. So this is focusing on some of the mental health. And again, some of the risk factors that we have identified is, of course, being exposed to the fires in the first place favors depression and higher anxiety in that cohort. So you can see that in this linear regression analysis. Pre-existing conditions, any pre-existing health conditions, and in particular, pre-existing mental health conditions also favored this higher depression score that people were reporting. What we also found was, of course, limited access to care, food insecurity, and displacement were risk factors for and favored favored having higher depression and as well as higher anxiety. But like Ruben mentioned, social support generally actually served as a strong protective factor, which was really promising to see. So that seemed to be in general. So social support more generally, increased degree of social support overall in the cohort seemed to be favoring lower depressive rates as well as lower anxiety, and as well as during the fires themselves. So social support that participants received during the fires also was a protective factor against these two some of these mental health metrics. We also looked at interactions of exposures on physical health symptoms that they self-reported, as well as quality of life. Quality of life we measured here by the number of days that they were suffering from health issues. That was explained in the mini survey. We again found that exposures, self-reported measures of exposures to the fires favored having more physical symptoms, as well as having more days affected with health issues. So poor quality of life. We also found, again, pre-existing conditions, in this case, some of the mental health or even some of the physical health conditions, such as having pre-existing lung health conditions, also favored having more physical symptoms. Limited access to care as well as food insecurity were also risk factors. But again, protective factors included having social support in general, as well as having social support during the fires that seemed to be associated strongly with not having these physical symptoms or having lower number of days with health issues. We also looked at interactions of exposures on specifically lung health because we saw how prevalent that was in the population that was affected by the fires and associated risk factors. Now, social support, unfortunately, didn't protect against having some of these conditions, but we did find, again, wildfire exposure tended to favor having these respiratory health outcomes and pre-existing conditions as well. Limited access to care and being of older age associated with having respiratory symptoms, as well as validating those symptoms using our spirometry measures. So again, some sobering results that showed, of course, the impacts of the fires and how they might be associated with these health outcomes directly. So we asked, well, what about the exposures that actually impacts health, and how does it do so? And in particular, lung health, since that was a huge prevalence in our population. So the Department of Health had a study that was sent out early on after the disaster, around in November. They surveyed 100 different properties in Lahaina and looked at the composition of the ash and the dust that was left behind and sent it out for evaluation. And they found that there was high levels of heavy metals from the ash in the fires that included things like arsenic, lead, antimony, cobalt, and copper at high levels. So we decided, well, okay, let's see what people might be impacted by more directly. And so we were able to collect specimens. Again, this is from urine samples from all the participants that we've included in the study and sent it out for inductively coupled plasma tandem mass spectrometry, which allows us to look at trace amounts of these metals, different elements, as well as these metals that were implicated in the ash from the Department of Health report, and in partnership with the Columbia University core facility. And this is what we found. So we sent out 667 samples. That was about half of the cohort so far for initial analysis of heavy metals. And we prioritized the ones that were implicated in the Department of Health report. And again, and you can see this is a distribution of the concentrations of heavy metals from the urine samples collected from participants, with the density showing basically the frequency of individuals exposed to those heavy metals, and the dashed line as the median value in that cohort. So you can see although the majority of the individuals are closer to it towards the median, and of course towards the lower end of the range in terms of the concentration of heavy metals, there were individuals, about 20% of participants, with higher levels of heavy metal concentrations, and including, again, arsenic, lead, antimony, cobalt, and others. We are starting to understand and look at associations of these potential contaminants on and exposures to health conditions. And so we looked at some of the heavy metal concentrations from the urine samples from individuals and their self-reported symptoms. And this included the most frequent symptoms that people were experiencing, such as eye and skin irritation. And we found that a strong association between those individuals that had exhibited or more frequent duration of symptoms tended to have higher levels of arsenic in the urine samples. Similarly, we also associated this with some of the lung health conditions that we saw using the spirometry measures, FEC and FEV1. For those of you familiar with those readouts, they're complementary. We found that at the lower end, which is the indicative of poor lung function, individuals that had low FEC and FEV1 scores on the spirometry, measure of lung health, tended to have higher levels of arsenic in their urine sample compared to those that had normal levels. In addition, we can also stratify based off of the severity of potential lung obstruction from the spirometry readouts, and those individuals that had more severe lung obstruction tended to have higher concentrations of arsenic in their urine. So of course, there's precedent for heavy metals and interacting with lung activity and function. This is a recent report in 2023 showing how mixtures of heavy metal have an influence on obstructive lung function, largely through oxidative stress and inflammation, which we think could be contributing to some of the results that we see here that could be associated with some of the recovery individuals might be experiencing. But in addition to lung health, we're also really concerned about what the implications of heavy metal exposures might mean and the varying concentrations in individuals and as they recover, because it has a wide range of effects, not just on lung health, of course, but can also contribute to increased cancer risk, as well as cardiovascular disease risk, and even neurological conditions, including depression and other mental health issues. So we're looking into that further in our study. One of the other challenges that we're facing is like, okay, well, we're starting to see now some of these heavy metals being from individuals exposed to the fires. What could potentially be the source? And of course, we're implicating the source from the fires themselves and the ash and the dust that they might have been exposed to during that day. But again, these are individuals that we are recruiting in the study now, which is about a year after they've been exposed. So could that mean that they're either re-exposed to these exposures, and we're seeing that in the results, or could there be other sources of potential chronic exposures that they could be exposed to in the wake of the fires, or even from just some of the situations that they're moved into now. And so there's this one other report that I'd like to share from 2023 that really describes heavy metal exposures from agricultural sources and direct and indirect exposures to that on human health. And so, as you all know, Maui is an area with a lot of agricultural activity, and there are concerns about potential heavy metals in the fertilizer that's used in agriculture that could be a source of exposures either from the fires or ongoing persisting exposures that people might be exposed to chronically. And so we're trying to dissociate the two and trying to understand that more comprehensively. But what I can tell you that is this is probably the best data that we have so far to show how direct exposures might be associated with some of the health conditions, the physical health conditions people are experiencing. And again, looking at lung health, because that was so prevalent in our population. So within around 1,000 participants that we were able to recruit into the study, about half of those participants lived in areas outside of the burn zone or away from the perimeter from the fire. But the other half were individuals that were living in the burn zone themselves. And these little dots, as you can see in Lahaina, are their geocoded residential addresses. So you can see how they compare within the fire zone perimeter, as well as the burn zone itself. And what we were able to do is stratify individuals based on their proxy to the fires and look at how their lung health was associated with that. And we found, in fact, that there was a strong relationship between those individuals that were living inside the burn zone or within the perimeter of the burn zone that had poor lung function. And this was statistically significant, showing that, of course, individuals that might have been more exposed to the fires directly had this corresponding poor lung health condition. And that was consistent with individuals that had already pre-existing lung health conditions. We also saw differences by race and ethnic groups, where Filipino population, as well as Native Hawaiians and Pacific Islanders and other Asian groups tended to have worse outcomes in terms of lung health compared to other groups. And this is another way to look at the data with an FEC reading, which is complementary, and it kind of validates some of that information, basically showing the same thing. Proximity mattered, and this was indicative here. Of course, this is preliminary, and we're still analyzing the data further, and this is, again, ongoing, so we're hoping to recruit our additional 2,000 participants, total participants before the end of the year so that we can understand this more comprehensively.
Almost there. So, okay, so this slide actually shows the real impact that MauiWES has been having on participant lives. Nearly half of the participants actually share their results with family and friends. This is actually what happened 6 months after, right? This is a survey that we had at the 6-month mark. But really what encourages us to see and continue this study is that many actually took steps to improve their health, such as following up with their healthcare provider, making lifestyle changes, and seeking additional screenings, where about 40% of them actually follow up with a healthcare provider. And the actions actually are demonstrating how MauiWES empowers individuals to take charge of their health, which is something that we saw that they were not doing before, where 60% of participants who came to the study, this is their first health screening since the fires. Where are we now? So right now, we're about to finish the recruitment of 2,000 individuals affected. We're hoping to, by the end of the year, get really close to this 2,000 number, including children, first responders, volunteers. But we're also launching the Maui Registry, which will allow us to do a more passive data collection of individuals. This has already been up and running, and every individual who is part of MauiWES is part of the registry. But anyone else who don't want to participate in MauiWES can be part of this registry for passive monitoring. One of the things that is important is that this registry is not only about collecting data, but it's actually providing services and making referrals to participants. So just some of the early lessons really quick from MauiWES. Well, this is showing us that while health often takes a backseat during disasters, it just doesn't have to stay that way. Through proactive screenings, real-time data, and tailored interventions, we are trying to close this gap and really empowering individuals to make a change in their health. And by assessing individuals' exposure to environmental hazards, and as well as integrating these long-term solutions, we are trying to build resiliency against this future disaster. So this is not only for this disaster, but this is for what comes next. We're also trying to train the next generation of students who are coming over. We have a team of like more than 20 participants who come over, 20 students who come over to our recruitment events to help support the data collection, as well as the people who are analyzing the data, right, in Hawaii, so in Honolulu. So yeah, this is, everything closing this loop. So the MauiWES study and registry is more than data collection effort. We're hoping that it's going to be a foundation for informed recovery and long-term decision making, hopefully with national implications. We're hoping that by providing these tangible benefits like consultations and connection to services, the registry is able to directly support participants while informing strategies to rebuild stronger, healthier communities. This vision ensures that the registry will become a vital tool for recovery, resiliency, and improving the lives of the people in Maui and beyond. So our critical goals for success are going to be on 3 areas. First, a community-centered focus where we aim to engage underserved populations by reflecting the needs and building trust through transparent and ongoing communication. The second one is we want to make sure that this registry provide policy-relevant outcomes, strengthening the registry to allocate resources equitable, provide actionable insights for informed decision-making. And lastly, we're trying to build a stronger system, a system that is committed to developing sustainable solutions to enhance health and resiliency for all affected populations, hopefully with strong partnerships with the healthcare sector and the state, and using innovative approaches. So today's event, so we're bringing experts, community members, partners, to share ideas and develop these strategies for resiliency and to improve the health of Maui community affected by the fire. We'll work together to strengthen the Maui Registry, making it a powerful tool for equitable recovery. So your expertise today is going to play a critical role in expanding the impact of this work, helping us create a system that supports the health and well-being of all affected individuals. So thank you for being here. And thank you to all the MauiWES sponsors and partners who are here. Okay. So, mahalo.